Hi guys, this video is about congenital cataract. So what is congenital cataract? It is opacification of crystalline lens or its capsule present at birth. So opacification of crystalline lens or its capsule is cataract. If it present at birth, we will call it congenital cataract. And it is the leading cause of treatable childhood blindness. So coming to the etiology, it is the rule of 1/3. That is, 1/3 is idiopathic. 1/3 is hereditary and autosomal dominant, and the other 1/3 is secondary, that can be due to maternal or fetal factors. So maternal factors include maternal infections, that are the torch infections, and the most prominent one is rubella, which will result in pearly white nuclear cataract. So rubella causes pearly white nuclear cataract, and there can be toxoplasmosis or cytomegalovirus causing the cataract. Then it can be due to metabolic disorders like galactosemia, where we will see oil droplet cataract, and Love syndrome. It can be due to chromosomal anomalies like Down syndrome or trisomy 13/18. It can also be due to maternal drug injections like corticosteroids, thalidomide, or due to malnutrition. So these are the etiologies of congenital cataract. 1/3 is idiopathic, 1/3 is hereditary, and 1/3 is secondary, which can be due to maternal infections, metabolic disorders like galactosemia, chromosomal anomalies like Down syndrome, or drug injection like corticosteroid, thalidomide, or due to malnutrition. Now coming to the types of cataract. So the morphological classification of congenital cataract include lamellar cataract, blue dot cataract, nuclear cataract, anterior polar cataract, posterior polar cataract, club-shaped cataract, and total congenital cataract. So coming to the lamellar cataract or the zonular cataract, the most common visually significant cataract. So this will cause significant vision loss. Here we can see opacity is in discrete zone of fetal nucleus. So here the opacity is in fetal nucleus, and the central cortex will be clear. So there will be clear cortex, and the opacity will be in the nucleus. That is the lamellar cataract. And also, since the opacity is in the nucleus, we can see riders or spokes in this cataract. So this is the lamellar cataract with riders or spokes, visually significant, and we can see this opacity is in the fetal nucleus. Now coming to nuclear cataract. This also involves the nucleus, that is the embryonal and fetal nucleus are more commonly involved, and they have variable involvement in case of the vision, and they include cataracta pulverulenta, which is the powdery opacity. So they involve that powdery opacity or cataracta pulverulenta. Now coming to the blue dot cataract, also known as punctata cerulae. This is the most common overall congenital cataract. Most common visually significant cataract was lamellar or the zonular cataract with the riders, but most common overall congenital cataract is blue dot cataract. So here we can see multiple blue in the periphery, and this is visually insignificant. In the periphery we can see multiple blue dots. And now coming to the anterior polar cataract. This is a pyramidal or reduplicated opacity found in the anterior pole, and posterior polar cataract are found in the posterior pole. And here we can see persistent hyaloid artery, also known as Mittendorf dot. So here we can see a Mittendorf dot, that is the persistent hyaloid artery, or there can also be posterior lenticonus. This is visually significant, that is, it is having a nodal point involvement, so this will be visually significant. Next cataract is club-shaped or coronary cataract, where we can see the opacities are arranged radially in the periphery. So if it is a lens, the opacities will be arranged radially in a club-shaped or coronary way. Now last one is total congenital cataract, where there will be a complete opacification, and they are seen in rubella with profound visual loss. So once again, what are the morphological type? It can be lamellar, it can be nuclear, blue dot, anterior polar, posterior polar, club-shaped, or total congenital cataract. Coming to the clinical evaluation, first we have to do an ocular examination. Look for leukocoria, that is the whitish reflex which can be seen in congenital cataracts, and visual assessment on fixation, light following, or nystagmus. For visual assessment, if the baby is following the light or fixing the light, that means they can see. Now morphology has to be looked through slit lamp or direct ophthalmoscopy. So leukocoria, visual assessment and morphology. Then do the systemic workup for torch titer, urine for the reducing substance to rule out the galactosemia, and physical examination to rule out cardiac defect in case of rubella or mental retardation in case of Love syndrome. Now coming to the management. First one is the non-surgical care. So here we will give mid-Pediatrics. When we will do non-surgical treatment? When the cataract is small small partial cataract. So this mydriatrics, what will they do? They will dilate the pupil and allow the light to pass through the clear periphery. So pupil will dilate and the light will pass through clear periphery. Next comes surgical one. So if it is bilateral dense cataract, we have to operate it in 6 to 8 weeks. But if it is unilateral, we have to do urgently. And what we are doing is lens aspiration or lensectomy. So in children less than 6 years of age, if we will do simple lens aspiration, there is 100% chance for posterior capsular opacification. So if the child is less than 6 years, what we should do is we should do a primary posterior capsulotomy and anterior vitrectomy. So we have to remove the posterior capsule and anterior vitreous also to prevent posterior capsular opacification. Then comes the IOL implantation. So after the lensectomy, we have to give a new lens. So if it is more than 2 years, we will give standard IOL, that is a hydrophobic acrylic foldable IOL. The standard primary IOL is hydrophobic acrylic foldable IOL. And if the child is less than 2 years, we will use contact lens or aphakic lens first. Then we will shift them to secondary IOL later. Then we have to give amblyopia therapy, that is the occlusion therapy. We will patch the good eye and allow to see with the other eye. So this should be rigorous and taken care to prevent amblyopia. So this was all about congenital cataract. Hope it was useful. Thank you.